All right, Dr. Allen, you can get us.
Should I start? Okay, perfect.
Yes.
Uh, Good morning, everybody. Thanks for joining us in such an early hour. My name is Nima Alan from UCSF Department of Neurosurgery, and we are presenting a journal club today on redefining the surgical risk for thoracic disc herniation via the mini open lateral thoracic discectomy approach. You saw the outline in the earlier slide. I'll begin by introducing the topic by presenting a case, and based on that, we will start our conversation, starting with Dr. Nathan Hahn, who is one of our fellows from University of Maryland, followed by Dr. Prablek, who is from Baylor, our other fellow who started this year. So let's see. Can everyone see my slide? I think it works.
Yes, that looks great.
Excellent. So this is a 64-year-old male with a thoracic myelopathy with multiple symptoms, including paresthesia, subjective leg weakness that manifested as a gait imbalance and urinary dysfunction, had a T7, T8 calcified thoracic disc herniation with cord compression and cord signal change. And before he saw me, he had seen another surgeon who recommended a posterior approach, the classic posterior approach with thoracic discectomy, lateral extracavitary approach with costotransversectomy, and pedicle screw at the level above and below. I recommended a different approach. I recommended the mini open lateral thoracic discectomy, which is based on my training at my fellowship with Dr. Uribe, that everything I learned with this approach is from him, and shout out to him. Hopefully he can join today. When I do this approach, I don't instrument. So the patient question was, do I need rods and screws? Why are you saying that I don't need rods and screws? When you do a lateral approach, intuitively patients want to know, what are you going to do with my lungs? The lungs in the way. And surgeons who do this approach have to confront with the potential complications of pneumo and hemothorax. We'll present a paper on that. And probably most importantly is mitigating the risk of intraoperative neurological decline, which could happen with any approach, but what is the risk of quote unquote becoming paralyzed during surgery? Those are the three main questions that the patient had for me, and through the efforts at UCSF and in my fellowship at Baylor Neurological Institute, we had some papers that could answer these questions to redefine these risks for a lateral thoracic discectomy. So we'll start by Dr. Hahn. Dr. Hahn, I'm going to stop sharing. Nathan, if you don't mind sharing your screen, he will present two papers on two of these questions, and then we'll have a panel discussion, and we'll go from there.
Got it. Can everybody see my screen okay?
Yes.
Yes.
All right. My name is Nathan, one of the neurosurgery fellows here. As Dr. Allen mentioned, I'll be discussing some of the questions that that patient had in terms of what are the risks of pneumothorax and what is the risk of spinal alignment after this lateral MIS thoracic discectomy. No conflicts or disclosures for me. So in terms of the pneumothorax, Dr. Allen himself had written a paper on what is the radiographic incidence and clinically significant incidence of pneumothorax and hemothorax after the MIS thoracic discectomy. The purpose of this study was to look at a retrospective single institution of all patients who underwent this procedure. And clinically significant pneumothorax or hemothorax was defined as those requiring an intervention such as a chest tube. It was a retrospective case series, and we were able to look at the post-op chest x-ray immediately after the surgery and subsequent days of the hospital stay to determine the extent of pneumothorax and whether it expanded or not. There were 30 patients that were included in this study, 20 male, 10 female. 15 of the patients underwent a right-sided approach. 3 patients underwent a pedicle fixation and fusion, and 15 of the patients had pneumothorax radiographically. However, only 2 of them were large and 13 of them were small on the immediate post-op chest x-ray, and none had a hemothorax to begin for immediate post-op x-rays. The large pneumothorax patient, the two of them, had to have a chest tube placed due to expansion of the pneumothorax, and one of the patients developed new hemothorax post-op day 6 and also had to have a chest tube placed. 5 patients were noted to have an intraoperative violation of the parietal pleura. However, there were no incidents of any visceral pleura violation. One of the important points of this paper was that none of these patients needed a prophylactic chest tube that needed to be placed, and none required a needle thoracostomy, reintubation, or thoracotomy for the pneumothorax. And this is an example of one of the patients. So actually, one of the patients had an contralateral large pneumothorax after the procedure, which was not related to the procedure itself, but it was also resolved with the insertion of a chest tube. So in terms of the results of the discussion, the clinically significant pneumothorax or hemothorax that was defined by the study was about 10%, 3 out of 30, which all resolved without any evidence of hemodynamic instability or respiratory distress for the patients. The study recommends that patients do not routinely need a prophylactic chest tube in terms of undergoing this MIS lateral thoracic discectomy, as there's no the patients do not really meet the criteria of a chest tube, and that close radiographic surveillance and symptom monitoring after the procedure is sufficient to identify patients requiring the intervention. And one thing to note is that out of the 3 patients that required a chest tube, only one was actually related to the immediate surgical approach related pneumothorax. The other one was a contralateral area pneumothorax due to line placement, and another one was a delayed development of a hemothorax. The advantage of the lateral thoracic discectomy is that you're able to meticulously dissect between the endothoracic fascia and parietal pleura to be able to safely retract the lung, and that the etiology of the iatrogenic pneumothorax with an intact visceral pleura is usually self-limited. So in conclusion, this approach does not really require prophylactic chest replacement, and it is safe. And those who have clinically significant pneumothorax or hemothorax can be managed post-operatively when necessary, safely. And moving on, in terms of looking at whether doing this procedure without hardware, screws or rods or plates, does this affect the overall long-term global spinal alignment after this procedure? And this question was also looked at in a retrospective single institution study. And these are the structures that are involved in the MIS LRP thoracic discectomy. The section of the overlying rib, the rib head of the costal vertebral joint, the ipsilateral pedicle of the caudal vertebral body, ligamentum flavum, the PLL, and the posterior third of the adjacent vertebral body. In terms of resecting this area, does this affect the global alignment and the segmental alignment? So in looking at the retrospective study, in terms of analyzing the radiographic analysis, an upright chest x-ray and standing scoliosis x-rays were reviewed 3 months, 6 months, 12 months, and 24 months post-operatively. The T2 to T12 Cobb angle and the kyphotic angle, and the segmental Cobb angle and kyphotic angle at the operative level, and the SVA were analyzed appropriately. These were the patient demographics of the patient who underwent the surgery. And most of the patients underwent a 1 disc level at 91%. And the levels were mostly at the T10, 11, and T11, 12 levels, with a type 1 disc herniation occupying less than 40% of the canal diameter, with 2/3 of them being calcified. The results of this study is that there were no significant differences between the pre and the last post-operative segmental and global Cobb angle and kyphosis. The mean duration of the follow-up was about 1 year or 13 months. And in terms of the discussion of the results is that despite the recession of all those anatomic areas that I mentioned, the global and the regional spinal alignment did not change significantly at a mean follow-up of 1 year. And by being able to avoid the hardware placement actually reduces a lot of the operative risk related to instrumentation, the operative cost, and surgical time. The paper does mention that fixation may be indicated in patients who require more anatomical dissection than what we mentioned before. if you need to treat more than 2 disc spaces, if they had prior hardware and have severe ankylosis. And obviously, with longer follow-up and a more higher case volume, can provide more accurate results in the future. And those were the 2 papers that I have discussed and will be open to discussion before we move on to the next 2 papers.
Nathan, thank you so much for the presentation. I see Sig is here and Lee's here. Hopefully, Vedat can join as well. Praveen couldn't. But let me start by asking this question. Let me clarify one thing, Nathan, about the first paper that you presented. None of them were a formal chest tube. They're all pigtail catheters placed in IR in a semi-elective, non-emergent manner. So one of the questions that came up during a review process of this paper was that, are you putting the patients at risk by, emergently putting a chest tube postoperatively? And none of those 3 patients required an emergent chest tube. That's one. And the other thing I was going to say is, of the 3 patients, well, you mentioned it's correct. One is contralateral, not related to procedure. Regardless, we counted it in to be truthful to the data. One patient had an incidental finding of, they call it a potential exudative process in the pleural space, that they put a pigtail catheter to tap it and drain it, and it was removed the next day. It was 2-week post-op. Again, we counted it in because on the side of the approach, for sake of integrity and honesty in the literature, in our reporting, we included it. And one was a true expanding pneumothorax that happened within 24 hours after surgery without a significant respiratory compromise that required a pigtail catheter. I'll start by asking our panelists, Sig.
Just really quick, this is Rod.
Oh, hi, Rod. Yeah, hi.
So I just have 2 quick questions on that first paper. Is do they drop the lungs, or when whenever I do these mini open lateral, when I first started doing this, we would drop the lung, and sometimes I do think that makes a difference. And so do you know if that was done?
No, it was. I know that it was not done. So these are not double lumen, intubation, and the reason we didn't do it is we thought that atelectasis may be a problem postoperatively.
Yeah. So I think, okay, that's important, because sometimes, this is what I always find with when you do these cases, and you do a post-op chest x-ray always, and there's always going to be a little bit of air around, right? And so, when I first started doing this, we did double lumen, we put chest tubes in everybody, and we kind of started, going in the direction of less invasive. And I don't know, Nima, and this is, I think, important for, whenever you're doing these approaches, is you do also get kind of this fluid collection, right? And so I think sometimes, and I can't remember if on that one x-ray, you can get kind of fooled between the lungs not fully expanding, and maybe there's a little bit of fluid collection. And so, like, we've had this too, we place pigtails and you get like 500 cc, And so I don't know, what are your thoughts on, is it fluid? Is it atelectasis? Could that have been part of the reason why some of those, or were they real pneumothoraxes?
So first of all, Dr. Hoskin, the reason I think we step away from that is pioneers like yourself and Dr. Riva, who did do those surgeries when this became more a prominent approach, that we learned that we probably don't need to put chest tube in up front and whatnot. So what you saw in Dr. Riva's experience is more towards his experience after he had learned from what you just said, that we probably don't need to put formal chest tube in, and this is a kind of testing that hypothesis. But back to your question, if you get a post-op MRI on a lumbar decompression, you always see fluid in there. I learned this from Vedat here. He doesn't get post-op chest X-ray because everybody gets confused by, is this a hemothorax? Is it a pneumothorax? Patients should get a pigtail and stuff like that. So I don't do a regular chest X-ray anymore. I've monitored them clinically, and we always leave a hemovac drain in, just like you would for a, say, a lumbar decompression or a thoracic decompression, to take the excess fluid out. From my experience here, I've done this about 5 times in the past year. The drain is removed in a day or two, and it puts out about 100, 200 cc's a day. And once it goes less than 100, I take it out.
Yeah, I mean, I do the same thing, Nima. I put a hemovac drain, and I leave it to suction for 2-3 days, and then right when the patient's about to leave, I take it out. I do get, the only reason I get chest X-ray post-op is that just so I can compare it, down the road. But I agree, I don't think you have to get a chest X-ray. And then the other thing that I think would also, and you'll find this out, is that the hospital coders, the X-ray will always be read as a pneumothorax. And so these sometimes get coded as a PSI, complication. And
Yes,
then
I got one of those emails. Yes.
That too, because then that stirs up a whole different thing. But I know that's not part of the discussion. But great presentation so far, you guys.
Thank you. I did get one of those emails, Dr. Oskin. My first case, I got an email that you had a pneumothorax. What did it happen? So
Yeah.
But yeah, and I think Vedat is trying to join. Corey, if you don't mind sending the link to Vedat directly again. Sorry.
Will do.
Thank you. And as for the instrumentation, Rod, do you put in a cage in the disc space, or do you just do kind of partial corpectomy and
partial corpectomy? It just depends. I mean, just like you guys, I think Juan and I, you don't need to, because you're just going unilateral. And unless you're doing a full corpectomy, and but in the thoracic spine, you can take a lot of bone off without doing any. As far as that's the nice thing about going lateral.
Sig and Lee, I know Lee is a proponent of posterior approach, which is why I wanted them to be here. What do you think about not instrumenting in these situations? Do you think it confers any benefit, any risks?
Hey, can you hear me okay, Nima?
Yes.
Okay, yeah, I agree. I mean, I don't think you need to instrument for majority of the cases if you're going lateral. And, I've done lateral throughout my training, and even a few cases in my own practice. I think it's a great study. It really kind of, characterizes the risk profile of the lateral approach. And, as you know, I'm a true believer that, I think as in our training, even as an attending, you should be familiar with all the different approaches and have that in your toolbox. And I don't think there's the 100% approach for just one single approach for all the pathologies. But I think the lateral really, you're trading the complications through the approach for a better visualization and easier cord decompression. Compared to the posterior lateral approach, it's a very familiar approach for most surgeons, the spine surgeons. And the downside is that you don't have a direct visualization of the cord. But complexity can be sort of supplemented by now, intraoperative ultrasound. And we published videos on operative neurosurgery where you can actually use it real time to guide the discectomy. I mean, I think as a surgeon, you have to decide in your hand and also in your institution, what works best for your patients. I think it's great, at the institutions such as UCSF and in Seattle. I mean, you have people doing different things, but so the trainees get exposure to different approaches. But in my hand, I think the case you showed. In fact, I have a thoracic disc on as a second case today. As exactly the same thing. Calcification centralized. In my hand, it's basically posterior lateral approach. If you can spare enough of the lateral pedicle and facet, you don't have to fuse even. But if you have to take a lot to kind of reach the midline, then I typically just fuse at the index level, not 2 levels, but index level. So, Sig, what are your thoughts?
Yeah.
Well, first of all, a terrific presentation, and I've had a chance to sit with Nima and go through some of these cases, and really impressive, Nima, that you're just taking out the posterior third of the disc, and I think that that's really the key to not instrumenting these. And I think to some extent going anteriorly, I would have a tendency to take out more of that, but you staying so focal with the posterior part. To your point, Lee, I also tend to prefer going posteriorly, but I think for some of these big calcified discs, I think there are instances where going anteriorly makes sense, especially if it's more of a bilateral involvement. I like to push things away from the cord rather than kind of reach back towards the cord. We're very comfortable with posterior-based approaches there. But this has been really impressive. In the absence of instrumentation, you demonstrated very definitively that there's no evidence of radiographic progression. And I think that's because you're doing such a good job of staying posteriorly to that posterior third. One of the questions I had for you, Nima, you had the one case of an expansile pneumothorax. Now, in that case, was there pleural injury? Because that to me would be the obvious situation where you want to.
Absolutely. So glad you brought it up, Sig. But by the way, Vedad just joined. Vedad does put a cage in. I was going to get his opinion on need for instrumentation in these cases. But to your question, Sig, I don't know the answer because I looked at the op report and I couldn't tell if there was parietal or visceral pleural violation. Having done these cases and seeing these cases, a couple of things happen. One, it's not uncommon to have parietal pleural violation. I think parietal pleural violation is okay in terms of what the risk is postoperatively in terms of your pneumothorax, because if you don't have a visceral pleural violation, it should be a self-limited phenomenon that you're not pushing air in or sucking air in as you're breathing. But the problem with the parietal pleural violation is sometimes it's occult, you don't actually see it. And the other thing is that once you have a parietal pleural violation, the visceral pleura totally behaves differently. It wants to basically mushroom into your surgical field. So it makes it more likely to have a visceral pleural violation, which if it happens, I think that's when it could result in a progressive and expansile pneumothorax. How can you tell if you have an occult injury that you didn't see it? One of the things that I learned from Dr. Uribe is that at the end of the case, I think Vedad does the same thing, that you put a red rubber tube in the surgical field in addition to your hemovac. With the red rubber tube, you close the fascia around it, you put a stitch, don't tie it. You do a Valsalva maneuver to push the air out. If you doing the Valsalva maneuver and the air keeps coming out and it doesn't stop, it means that you probably have a visceral pleural violation somewhere, that as they're doing a Valsalva, air keeps coming into the field. So that's an indication to know that you do have a visceral pleural violation somewhere. You may have seen it, it may have been occult, and you should be on the watch out for those particular patients that if they're going to have a progressive kind of phenomenon with pneumothorax that may require chest tube. If I could get Vedad's opinion on, we were discussing the need for instrumentation. We presented a paper from Barrow that up to 2-year follow-up, segmental coronal Cobb angle and kyphosis, and also regional in the thoracic spine stayed stable. I know that Vedad, you put instrumentation in. What's your thought on the need for putting a cage in at the index level?
Well, if you look at the incidence of the thoracic disc herniation, like almost like 70 to 80% of them is between T10 to L1. And that segment is not as stable as the higher thoracic levels.
Mm-hmm.
And I don't think that it's really absolutely necessary in the higher levels, like, T7, 8, 8, 9, 6, 7. But I believe that it is, if it is T10 and below or T9 and below, I think instrumentation is needed because dead segments are not as stable as the higher levels.
So with a false rib, basically putting an instrumentation may help.
Yes, I mean, in the past, we were doing cervical discectomies without any instrumentation. We were just doing the discectomies. And I think it makes it a little bit more stable. And sometimes, like, when you are doing all these, like, you're taking quite a bit bone to decompress the canal.
Yeah.
I can't tell you how unstable that segment after the corpectomy is. I mean, it's just not just the discectomy, you're taking quite a bit bone.
Rib bed, yeah.
Yeah. So that's why I believe that the stabilization would be much safer. It might be a little bit more costly, but it's safer.
There.
But I agree with the pneumothorax. I mean, I'm not afraid of patients getting pneumothorax. Like you mentioned, it's not a tension pneumothorax. It's like, it's some air that in the field. And I put drain on every cases.
Yes. Well, excellent discussion. I think if there's any no further comments, we'll proceed to Dr.
There's
Prablik.
a comment in the chat about endoscopic approaches. Do you want to start with that?
Well, I'm glad it was brought up. I don't do endoscopic. We are gonna start an endoscopic program here at UCSF, but we don't have endoscopy here yet. We will, and once we do have it, I think there is definitely a role for endoscopy for doing thoracic discectomies, especially the soft thoracic disc. So we talked about that one case that you had. I think it's a pretty slick technique to be able to spare the patient a lot of the bony work and being able to put your endoscope in essentially transforaminally and then pulling that away by a small partial corpectomy that you can push the thoracic fragment into that space. Yes, I think there's a role. I don't know if there is a role in the larger calcified discs, but I think it's definitely a tool that could address some of these patients' problems.
Hey, Nima, before we move on, just one quick point. Can you, from your experience, how do you, what's the frequency that you see, post-op, people having pain from, like, let's say the intercostal nerves, whatnot, and how do you manage, that's something, yeah.
Yeah, that's a great point. I think Mark is going to address that in this paper from Vedat's experience at UCSF. Great point, and I think that's one of the discussions to have with the patients in terms of the neurological sequelae of this approach versus the posterior approach. You're dealing with different risks, which is the kind of topic of this journal club. How do you redefine this risk? Mark, that's a good segue. Let's start with your paper.
All right, thank you, Dr. Allen. Everybody can see everything okay?
Yes.
All right, so hi, I'm Mark Prablik. I'm one of the spine fellows here at UCSF this year, and I'll be presenting 2 more papers on the topic of this minimally invasive approach to lateral thoracic disc herniations. No relevant disclosures. We'll start with this paper from the group at UCSF in 2018. Just a little bit of background, as we've already mentioned, thoracic disc herniations are rare. Patients present with myelopathy and radiculopathy. It's challenging to us to both select the correct approach and execute it appropriately. But as Dr. Tan mentioned, the more we learn about all the different tools that we have in our toolbox, I think the more appropriately we can help patients with this pathology. This paper in particular was a prospectively collected single surgeon database collected from 2007 to 2016 who underwent lateral transthoracic discectomy. I wasn't 100% sure on how many patients underwent thoracic interbody fusion, but there were a certain proportion of patients who had interbody cages placed as well. The approaches in this database were both transpleural and retropleural, and outcomes were assessed at 1 month, 3 months, 6 months, 1 year, and then annually thereafter. Paper starts with a technical description of the lateral discectomy. placing the patient on a table with a brake and a brake approximately at the level of the pathology, and then utilizing fluoroscopy to localize the level, and also with the help of a previously placed thoracic fiducial. The paper then describes sort of finger dissection between the pleural and the intothoracic fascia, and with placement of a lateral type retractor between the ribs, which is then used to sort of spread the operative field so that you can see the pathology clearly. They also describe a technique for resection of the rib head at the level of pathology for further exposure of the disc herniation, and then a sort of wedge osteotomy described in panel D to further expose the disc with placement eventually of an interbody cage there. Demographically, most of the disc herniations were T1011 and T1112, although the single most common level was T78, but tends to happen a little bit lower down in the thoracic spine towards the thoracolumbar junction. And there was a significant proportion of patients with calcified disc herniations, about 46%, and then a lot of patients had central disc herniations, about 60%. Which may have been the reason why the lateral approach was chosen, because it's hard to get there from one side or the other from the posterior lateral approach. And this is sort of the main slide that I think Dr. Alan just mentioned. It shows the complications associated with the procedure. Notably, no patients had neurological deterioration. There was one patient who developed pseudoarthrosis and then needed posterior lateral fusion, I think 3 or 4 years after the index surgery, and then a couple patients with a PE and pneumonia perioperatively. There were 5 patients with dural tear, which were repaired primarily with the help of a myofascial patch, and no issues with CSF fistula or persistent CSF leakage follow-up. And then, as Dr. Tan mentioned, there were 3 patients, or about 5% of patients, with intercostal neuralgia. So, that is some risk associated with this approach, usually just from the approach and dissection getting around the ribs. And then finally, 91% of patients had improvement in their myelopathy symptoms. So these patients tend to get better neurologically. The actual most common presenting symptom in this series was back pain. And so SF36 scores and ODI scores were also improved at follow-up as well. And as I mentioned, there were no long-term neurologic motor complications in the series. And so we'll move on to the second paper, which is again from the group here at UCSF. Which is a sort of technical description and review of the literature around addressing thoracic discs through the minimally invasive lateral approach. Again, we'll note that thoracic disc herniations are uncommon but important pathologies, which are challenging for us to treat. Just a few things to highlight about the operative approach here is that they used navigation with the reference frame fixated on the iliac bone. And then they used the navigation trajectory to plan their skin incision. And then they made the incision over the rib with the placement of an MIS retractor with drilling and bony work with navigation. And then before closing, what the authors describe is placing a pigtail catheter and then performing a Valsalva maneuver so that any excess air in the field is sort of forced out through the pigtail catheter prior to closing. They also go on to describe a couple methods of dealing with lower thoracic herniations at the level of the diaphragm. There are some papers that describe diaphragmatic detachment. These authors describe a diaphragmatic splitting technique. They talk about sort of splitting the fibers of the diaphragm as one split the fibers of the psoas for a lateral lumbar approach, and they had success with this technique. These are just a few demonstrative pictures showing the use of navigation and projection here. Showing dissection circumferentially around the rib and then after resection, showing the retroportal space, and then showing the disc space once the retractor is placed, which allows for good visualization of the pathology. The paper then goes on to describe some previous papers in the literature. Karakari et al. Shows improved clinical outcomes via BAS and ODI, and improved alignment associated with interbody fusion. And then Nakar et al. Show improvement in myelopathy, ODI, and SF-36 scores after an anterior approach. This paper also references the paper that I just presented as far as showing a large series of patients who do well neurologically without a lot of significant complications. So just a summary, these minimally invasive or mini open transthoracic approaches are feasible. We can use surgeon-aiding technologies such as navigation in order to help facilitate them. Many series report encouraging outcomes with regards to neurologic function and surgical complications, which Dr. Hahn talked about. And then lateral approaches do offer some advantages over posterior lateral approaches. A lower risk of neurologic complications. The paper cites a large review of posterior and posterior lateral surgeries with 18% of patients undergoing those approaches having neurologic deterioration, bilateral leg weakness, paraparesis, and paraplegia. And in contrast, the lateral approach, at least in the series that we've examined here today, have a relatively mild complication profile and may help you avoid the need for instrumentation and fusion, which is often of interest to patients as well. So, thank you all very much.
Thank you so much for the excellent presentation. I'm going to go back to Lee's question about the intercostal neuralgia. I believe it was about 5%. It is actually a very debilitating type of pain. But what's your experience with dealing with these symptomatic intercostal neuralgias postoperatively? And what do you think causes it?
I think you are damaging the DRG when you are exposing to the disc. In my experience, like when that happened, actually, you are right. It's extremely uncomfortable in some of the patients. I had, I think 2 or 3 patients that, very, uncomfortable discomfort. And think in one of them, I went back. Maybe it wasn't on this series. Went back and, resolved me the nerve root at the, next to the dura. I tried epidural injections, usually not helpful. Medications like gabapentin, Lyrica is not helpful. It's quite uncomfortable for the patients. I think it's the exposure, like, when you're like doing the corpectomies and, cutting the bone and then trying to push it away from it, then you just probably keep hitting to the DRGs. Or one of the other reasons could be like, like when you're doing the root resection, you can't just like, damage the intercostal nerve. Distal to the DRG, then patients develop an, radiculopathy. It's a difficult problem to deal. I think absolutely needs to be discussed with the patient. I can't tell, like, predict like which patient is going to get, which patient is not. It's almost impossible. But it's a valid point. That's like, significant risk for the patients because it's quite, disabling. On the other hand, I just want to talk about the other complication as well. Like, if you think about the calcified thoracic disc and you've seen that there was like 5 patients with the dural tear, I think that's much more difficult to deal with, thoracic dural tears. But if you are doing, thoracic disc herniation, if you do it enough, you're going to see dural tears. It doesn't matter posterior, lateral, costal transversectomy, you're going to deal with the dural tears. Mm-hmm. One thing that I realized that in the lateral approach, I think you have to repair. You can't just like put TCL and other stuff to try to seal it. I tried and it doesn't usually work. And the one thing that I figured out that the most effective way to do it, after putting a couple stitches, that is very difficult. It takes a long time to put those stitches in. So the void that you created, you cut a really decent piece of latissimus from the muscle, and then put it in there, and then put the plate on top of it. It's literally like putting a cork on a bottle.
Hmm.
And then you literally plug that area and nothing comes out. So whenever I did that, actually, there was no CSF leak post-op. I strongly recommend, but it's not just the small muscle pieces. You need to fill the void with the muscle.
You mean in the partial corpectomy cavity, you put a piece of muscle,
Yes,
you
and
hold
then
it in
put the
place
plate.
with the plate. Yeah,
Yeah, you don't need to put a suture. You just put a plate on top of it.
to hold it.
And then there is no space to leak anything, so it just flows whatever that leak is. I had one patient most of them are actually small tears. I had one of them who has a big defect, and I didn't have a chance to repair, put any sutures. I just put the muscles and no symptoms, no leak whatsoever.
There. Lumbar drain post-op after the CSF leak?
No.
No. Okay.
Uh,
yeah.
I mean, I haven't yet. I mean, of course, there is some value of putting the lumbar drains, but
Sure. Yeah.
I haven't yet. So,
what's your thought? The thing with CSF leak, if you have a ventral CSF leak and a posterior approach, I think it's an equally challenging problem to deal with. Lee, what's your thought on these ventral CSF leaks?
It can be tough to repair, but I personally, I think if you get it posteriorly, it's easier to repair because we do ventral CSF leak repairs through a posterolateral approach. And if it happens, typically sometimes you have to do transdural repair, meaning open the dorsal dura to see the ventral leak, repair the ventral leak, close the dorsal dura. And I had a case which I think Nathan is writing up is where posterolaterally a huge giant calcified disc. We have to do transdural posterolateral resection to kind of get the the cord and the disc sort of margin, so that you can basically open the dura so you can see where the disc is pushing the cord, and then you push the disc away from the cord because you already hollowed out the posterior third of the vertebral body, just like doing a posterolateral VCR, except you don't have to do the whole thing, just posterolaterally hollow out the floor and then push it away. So I mean, I think you don't want to get a CSF leak regardless which approach, but again, a little bit personal bias is that if you do get a CSF leak posteriorly, you're a little closer to the defect. It's easier to suture. And also, use of ultrasound, I'm a big proponent of it, is that, you can see sort of visualize where the disc is pushing against the dura ventrally. And then when you use the Dungoing pirouette or Woodson to kind of push down that shelf of bone, I totally agree with, I think Sig mentioned this, that you never want to sort of pull towards a cord, all the forces away from the cord. So the key thing for a posterior lateral approach is that you hollow out the floor of the disc herniation, and then you work your way, kind of push the part that's right against the cord away from the cord. I think that's the way to minimize or even eliminate the neural deficit post-op.
Absolutely. I think central tenet of any approach to thoracic discectomy is push away from the cord, which is why the partial corpectomy cavity is created by either posterior approach or lateral approach. So yeah, you have that room to push away from the cord. With regard to the neuralgia, just a quick comment. The neuralgia in these cases are almost similar to C2, the occipital neuralgia you get in C1, C2, if you're not careful about how you sacrifice a nerve. If you're doing with a thoracic discectomy, this is different for a corpectomy. With corpectomy, you land exactly where the nerve comes at you, and you almost invariably have to sacrifice a nerve root. If you sacrifice a nerve root, and you're often post-ganglionic in these lateral approaches because it's hard to see proximal to the ganglion, I think now you're committed to dissect the nerve a little bit more just to see where the ganglion is, to essentially extend your nerve root sacrifice more proximally, so you're pre-ganglionic, to spur them the neuralgia. that's one comment. And the other thing I was going to say, when we're talking about the neurological complications for a thoracic disc, for me, the evidence is pretty convincing that neurological decline intraoperatively is less likely in a lateral approach. I'm not saying it's true for every surgeon or every patient, but generally speaking, and based on population studies, it's less. So you're basically telling the patient you're exchanging one risk with the other, the risk of potential neurological decline with postoperative neuralgia, not to minimize the impact of neuralgia on the patient's outcome postoperatively, but I personally would have that trade-off. Improved neurological function in terms of cord function versus nerve root function with neuralgia. Sig, any thought on CSF leak? Because I know when I showed you on one case, the first question you asked me was like, what are you going to do if you have a CSF leak?
Well, certainly the idea of having a fistula, pleural CSF fistula, is concerning. And the big difference between anterior and posterior is going to be the negative pressure, right? So if you get through the parietal pleura, then there's going to be negative pressure in the pleural space. And I know of one case where that became a very difficult problem. But that pointed out in his paper, significant incidence 8.5% of CSF leaks, and I think Vedette's solution in terms of packing off that space seems to be very effective. But that's a big difference in terms of if you're going to get a CSF leak. And I think with some of these calcified discs, these are high-risk procedures. The big difference is being able to reliably stay out of the parietal pleura. If you're behind a parietal pleura on the approach, it's not going to be a big problem, I think, even with an anterior approach.
Absolutely.
I think just briefly with regard to tying off the DRG routinely, or tying off the nerve root pre or post DRG, what are your thoughts, Nima, about a pre-ganglionic tying off of the nerve root on the left side? Do you have any concerns about compromising the anterior? They're already good. So basically, the segmental blood supply to the cord.
Absolutely.
Like a test tie, or how do you do that?
I think every time you take it, you're risking sacrifice of basically compromising ASA. Couple of things. One, we were in a panel yesterday with Lee, Aaron Clark. We were talking about doing VCR for tumors and need for embolization and whatnot. But one of the things that Aaron mentioned, which I agree with, is you never know where Adamkowitz comes from. I know the teaching is it's on the left side, lower thoracic, but I've had patients who had bilateral supply. I had them at like mid-thoracic. Last case I remember, I had to do a T7 VCR, and the ASA was supplied by right side above and left side below. I just happened to get lucky with that level to be able to do a VCR. I think there are some studies that says doing preoperative spine angio helps to identify that Adamkowitz to mitigate that risk. I think every time you take the thoracic nerve root without knowing exactly where Adamkowitz comes from, you're risking it. Having said that, I think there are collaterals that a single level nerve root sacrifice probably be okay, but you're basically speaking about you have a 0% risk to something more than 0%. And you don't know what that risk is if you don't have an angiogram to know exactly where ASA is coming from. But it's the same issue when we're doing tumor VCRs, and then if you don't have that information pre-op, it's very hard to know which nerve root you're sacrificing in terms of its contribution to the ASA. Any thought on that, Lee? I know.
I typically don't have to take the nerve root from posterior lateral approach, but because it's kind of above the disc herniation typically. But for VCRs for deformity or tumor, when we do, and typically just test clamp the nerve root. Well, I have to say, but doing so many that the chance of it actually change the neural monitoring, it's pretty low, and usually it's due to hemodynamic sort of variation, and they bump the map up. It's not a problem. But I totally agree with you. There's an anatomical study that the Adamkiewicz is more likely to be on the left side, but it can be on the right side. It goes anywhere from T7 down to T12, whatnot. So it's a crapshoot where it's gonna be. So
I agree. I want to emphasize one thing. I don't sacrifice nerve root in a thoracic discectomy because exactly the same reason that you mentioned. I don't think you need to because where the disc is relative to the nerve root. Lateral thoracic corpectomy, different story because it's right in your face and you have to take it. Without any experience with ASA compromise from nerve root sacrifice and whether thoracic discectomy or lateral corpectomies or anything like that?
So that's exactly what I was thinking. Like I've been, at UCSF practicing in 2001, not just for myself and, including all the surgeons, neuro and ortho. I remember like for last 20 years, only one case, which wasn't mine, but it was before the Children's Hospital actually like moved to the, Mission Bay. It was an AIS patient with the thoracic fusion. I don't know if it was the vascular compromise or like, the cord is affected. So if you think about the possible incidence of like, cord, vascular issues, with all these corpectomies, discectomies that we all collectively to do together, like, I think the incidence is extremely, extremely low. And in terms of like, the nerve root compromise, I think there was like this animal study that they shown that the incidence of cord vascular compromise increases if you ligate 3 nerve roots bilaterally around the cord. Anything less than that, they didn't find any significant increase. I think it was done on they used the dog, and they ligate 3 nerve roots bilaterally. Then they seen that potential neurologic compromise. But before that, I mean, it wasn't 100% either. Even with the 3 nerve roots bilateral ligation, the risk wasn't that high. We did so many unblocked resections, corpectomies, and we ligate the nerve roots all the time. And with those corpectomies, not just the nerve roots, like, I can tell you that there's no segmental vessels working either after you do corpectomies. I think the incidence is very low. And I had only one experience that I don't test it, I don't clamp it, I don't I stopped doing that. One young guy with the giant cell tumor that we were doing on block dissection, and we happened to put a clamp on the segmental before we ligate, and we lost the signals after the clamp. But we got lucky. I don't know why we put a clamp on that one, but I still, it's not a routine practice for me to put the clamp and test it. I think the incidence is extremely, extremely low.
I agree. I think that concept about multiple contiguous levels being sacrificed at once. These collaterals, I've also spoke to our endovascular colleagues. The collaterals sometimes are underappreciated on those angiograms. That may not be functionally relevant, but if one is sacrificed, they do become functionally relevant, which is exactly what you're saying.
I just want to add one more thing. I think the incidence is more common in pediatric population. I think they don't have collaterals.
Yeah, good point.
I don't remember if anybody remembers, elderly populations, seeing, the neurologic deterioration after ligating segmental. So I think it's more common in ARS patients and more concerning than any other adult population.
Excellent point. I think we have 5 more minutes. Excellent discussion. Let me conclude this case presentation with this patient with a T7, T8 thoracic discectomy. We did a right-sided lateral thoracic mini open approach for thoracic discectomy. It was uncomplicated intraoperatively. unchanged motor and unchanged SSCP. I do check prepositions before I even turn to patients. I think it does help to kind of set a baseline before the patient is even positioned. No pneumothorax, hemothorax postoperatively. 9-month follow-up with an immediate improvement in the paresthesias and some gait balance improvement at 9 months, but it still was persistent. He did go from using a walker to using a cane, and his urinary dysfunction preoperatively persisted and did not improve. And these are the images I'll show you again to emphasize the the kind of partial corpectomy bottom half, 1/3, and the top 1/3 half of the adjacent segments to create this cavity and push this into this cavity that you create. This is the MRI. In terms of the question about what happened with the segmental kyphosis and regional kyphosis, segmental coronal cob angle changed a degree, and regional cob angle changed 4 degrees. Both of them increased, but I think both are within errors of measurement. Segmental kyphosis stayed the same, and regional kyphosis. Pardon the absolute gross misspelling there. I apologize.
Hey, Nima, really quick, this is can you go back to the, did you use navigation? Because I think one of the learning points about any thoracic disc is getting the right level.
Yeah, glad you mentioned that, Rod. I put a fiducial marker preoperatively with our IR folks that helps to take away that risk, reduce the cognitive load. I don't use navigation, but I use that fiducial marker and look for that intraoperatively to mitigate that risk. I don't know if Vedat or Lee do the same thing, or on SIG.
I use the fiducial markers every single case.
Okay.
Yeah, I just I don't use fiducial markers, but count the ribs above and below, and knowing the anatomy on the scoli X-rays and CT to know whether they have 12 ribs or 11 or 13, whatnot. Also, the posterior approach is nice that once you do the LAMI, before you do the transperpendicular approach, you get the ultrasound and check and make sure that there is a disc to be resected anteriorly. So
You said you don't use a fiducial marker?
I don't. No.
Yeah. Sig, what about you?
Yeah, I definitely prefer a fiducial marker unless there's some unmistakable radiographic thing. For example, maybe thoracolumbar junction with clear ribs, maybe a fracture, so it's unmistakable. But otherwise, I definitely prefer a fiducial marker. Lee, one point about the ultrasound, it's a little too late after you, because by the time you do the laminectomy, you can't do the ultrasound until then. So I've got a low threshold to put a fiducial marker in.
Dr. Oskren, what do you do that, or?
We publish this, and it's important to get, at least for me, it's so hard to see I don't know how, I always get a CT even after the fiducial is placed.
Yes.
Because I've actually had 2 cases where they put it 1 level below or 1 level above. So even the radiologist can get it wrong, and it's really hard to count the ribs, the levels, especially in a lateral position. So I always get a fiducial.
I agree with you 100%. I think if the service and technology is available to put the fiducial marker, I'll do it. And I do check, and I think here routinely we do get a postoperative CT. Our radiologists do, and they obviously dictate where they put it, and I check myself to see where it is relevant to the disc. But I think with that we can conclude at 7 a.m. I hope this journal club was informative about redefining the risk of thoracic discectomy via meaning open lateral approach. And Dr. Oskren, thank you so much for the invitation. I think we'll conclude with that.
Great job, Nima, and the UCSF team. Always good to see you, and glad you guys were able to join.
Great. Thank you so much. Thanks, everyone. Thanks, Lee, Vedat, Sig, and our fellows.
Great
Thank
job.
you.
Thank you.
Thank you.